Thank you very much. Can everyone hear me okay? I'm sorry if you can hear me okay, I can talk quietly. So this is 10 years ago, this is a TAVR in our lab. Look at the drama. I mean, all of these people, I don't even know where I am. I couldn't see myself in this picture, but huge drama. There's more behind the scenes. TAVR was exciting, but also a little bit scary, and that's only 10 years ago. This is last year. Look at this now. How boring has TAVR become? So this is one of the fellows. He gets all the accesses. This is the surgeon. Somewhere there's a valve technician. I'll walk in at some stage. I'll stand here, literally do nothing, flush the syringes, hand the wires. My most important role in TAVR now is to tell the fellow, wonderful job, you did a great job. You know, the young generation, they need to be told these positive things. So that's my most important role now. So TAVR has evolved rapidly over the last 10 years. It's become boring 98% of the time, but it remains super exciting 2% of the time. I do want to mention just one thing about TAVR in the modern era is our difference in thinking. And the difference in thinking is in patient selection. This has changed now with low-risk patients. So we used to consider TAVR as immediate treatment of a life-threatening condition, but now when we see particularly the younger patients, we're saying this is a lifelong management of aortic stenosis. We're not just thinking about procedure number 1, we're thinking about 8, 10, 12 years, procedure number 2. Another 12 years, procedure number 3. And that is critical when we assess the patient at baseline. And you had an amazing presentation this morning by Dr. Sondergaard, who explained TAVR beautifully. And I want to just use this as one example of what I mean by the lifelong management of aortic stenosis. So this is what we're typically doing now. The original TAVRs, we would place 80% aortic, 20% ventricular. The newer TAVRs now are placed almost zero with flush with the annulus. And because there's no interaction with the membranous septum and left bundle, there are probably lower rates of permanent pacemaker, low rates of conduction defects. Sounds like a great thing, right? Fewer pacemakers with TAVR. But what about when this patient comes back in 10 years' time with a valve degenerated and they need another TAVR? Does it matter where we place this TAVR at baseline? It does matter. So here's an animation. And look, you see the skirt here, the valve is opening, and now we put a new valve inside, and the valve leaflets are now pinned to the side. So the second valve has pinned open the first valve's leaflets. In other words, the new TAVR has converted the first TAVR into a covered stent. Right? Everything's been held to one side. So if in this patient you would initially implant it high, if they have a narrow or low sinotubular junction, you can now be effectively placing a covered stent in that aortic root and sequestering the sinus and reducing coronary flow, potentially making a TAVR not possible. So when we see patients at baseline, we now are very careful. We consider their lifelong management. If they're young, are they going to need 2 procedures, 3 procedures? Should we do surgery now so we can make it TAVR when they're a little bit older? These are the sorts of things that go through our mind that even 5 years ago, I'd say we didn't think about enough. So what makes a TAVR team? I'm lucky enough to have all of these people, these experts who work with me, but I'm going to have you look at all of these people, all of these experts, and ask yourself, what is the minimum that makes up a TAVR team? Of course, the interventionist, and of course, the patient. And I think there are 2 things that make a minimum. You can pick all the others. I think many MDs can do an echo, maybe can put a pacemaker, but what is absolutely critical, in my personal opinion, is involvement of a surgeon to be your bailout, but also to assess that patient at baseline to see, are they a surgical candidate for now, and maybe to do the procedure with you like they do in the United States. And the second most important, or equally important, is an industry partner. If you have a good partnership with industries, their technician, their valve specialist, they will do the CT analyses for you. You saw it this morning, amazing 3 Mensio CT analyses, all done by their industry people. They'll come and make the valve for you, they'll guide you, they do this day in, day out. They really are the lifeblood, the linchpin of your TAVR procedure. This, I think, constitutes a minimum TAVR team. So I will stress that this is a personal view. You heard some amazing comments from Dr. Sondergaard about how he does and how others do things. This is my personal view. If you're going to start a TAVR program, this is what I would say. Number 1, learn CT. Not full CT. You need to learn how to do a TAVR CT assessment, how to assess the aortic root, the left ventricular outflow tract, and the peripheral access. But even if you don't do it that well, your industry partners will do it better for you. They'll teach you, but they'll do a better job. I'll tell you as in a story, at our place, our TAVR CTs are assessed by a cardiac radiologist. They're assessed by a structural fellow. They're assessed by the consultant. Sorry. That's 3 people, and then they're assessed by industry. And when we see a discrepancy in the sizing and between all these 4 people, and we re-look, who gets it right every time is the industry person. So we may have got it wrong. So you can learn CT, but you should partner with industry. Now, I put down here retrain in femoral access, and I know what you're thinking. You're thinking, I have done thousands of femoral arteries. Who is this guy telling me that I don't know how to do femoral access? I will say you have to be humble. If you're not humble now when you're starting a TAVR program, I promise you, you'll be humble in 6 or 12 months when you have your femoral complication. You need to retrain in femoral access, and by retrain, quadruple guidance for femoral access, in my opinion. We use the CTA, we scrutinize the CT angiogram, fluoroscopy, ultrasound I think is mandatory now, as well as manual pressure, manual palpation may be also important. Here's a quick example of a CT 3D reconstruction, beautiful, no calcium, straight shot, but you'll see there's a high bifurcation common femoral over here and a normal bifurcation over here. So this would suggest we would prefer to go from the right side and not the left side. So CT analysis is important, but also fluoroscopy, ultrasound, and manual pressure. Micropuncture, I also think, personally, is critical. And if you hit the wrong point in the femoral artery, if it's not perfect with the micropuncture needle, you can pull out, you can press for 5 minutes, and you can start again. You have not lost anything. It's critical to hit the right spot. You saw this morning a fantastic demonstration of pre-close. I think I won't go through this, but there's different techniques, single or double per-close. And if I knew I was going to start a TAVR program in 3 months, I would be doing all my patients femoral, and I'd be putting a per-close in every single one of these patients. If you get that right, the access and the per-close, I promise you, you're off to the best possible start for a TAVR program. Peripheral training, I think it's very helpful to have selective exposure to peripheral training. You don't need a full peripheral fellowship doing complex treatments in the infrapopliteal region, but if you are able to approach the iliofemoral arteries from a radial, you know the equipment, you know the sheaths to get there, the wires, or you know how to do a crossover like you saw this morning from the contralateral femoral, that is extremely valuable for TAVR management. You will need to be aware of the balloons that are used for the iliofemoral vasculature, the names, the brands, the sizes, the types. The balloons we use for dry closure, meaning in the iliac artery to reduce downstream flow to help with femoral hemostasis, leak control, or pinched or dissected common femoral artery after you've used a per-close. And also you need to be aware that the self-expanding and the balloon expandable types of covered stents that will occasionally be necessary. You'll need to understand what size sheath you need, how you get it delivered. If you have this selective, not comprehensive, just selective peripheral training, this will stand you in very good stead. So a case example here. This is a 76-year-old male with a persistent femoral bleed. So he was obese, on Plavix, heparinized. He had straightforward, perfect femoral access with pre-close. He had a right radial 6-French sheath. We use radial for our secondary pigtail access. One side note here, this is a long 6-French sheath. It's the only time we use a long sheath, and the reason being is if you need to use a peripheral balloon from the radial access, once that balloon has been used, it's very kind of bulky and winged, and it's easier to pull it back, less trauma to the radial artery if you have a long sheath in compared to having a short sheath in. That's just a side note. TAVR went in, and no femoral hemostasis after per-close. So this is gushing out femoral artery. So what we did in this case was we put a third per-close in. We still had wire access. That didn't work. We put an angioseal in, lost wire access, still bleeding. We reversed with prosamine. We pressed for 20 minutes. We put an 8mm balloon from the radial up in the common iliac artery to stop flow. Continued bleeding despite all of this. So here's a picture, and you see here still a brisk bleed from the common femoral artery despite all of those maneuvers that I told you. In this case, we exchanged the right radial sheath for a long sheath, 120 centimeter sheath. We used a 6mm balloon directly over the femoral puncture site over here. We exchanged this 035 wire for an 014 wire, meaning the lumen still has space, and you can measure the end hole pressure in the lumen here. And then you can dial down the atmospheres of the balloon until you see the beginning of a waveform, it's a dampened waveform. That means there is enough blood just percolating in this region to supply all the good thrombin and stuff that causes that can allow a clot to form over the femoral artery. And this was that bleed I showed you just here, bleeding away, and this is after the femoral for 8 minutes, complete closure here. So having that ability, knowing your equipment, is a good way to seal the femoral artery. Another case here, an 82-year-old male who had ongoing brisk bleeding after Perclose. We put an 8 French sheath back in the femoral artery. It was still bleeding around there. Tried an angioseal, didn't work. Protamine pressure. Used this 7mm balloon in the external iliac to try and stop flow for a little while. And here's what happens if you inject through the lumen of this balloon. Look at what happened with this case. This is not good, right? There's no flow going down over here. So this is either thrombus or it's dissection. If you pull the balloon back, you see now it's occluded over here, but there's collaterals supplying the femoral, but this is occluded, and we can cross that with a wire from the radial, put a long balloon in, and it turns out that that opened it up. This is all dissection, but there's now brisk flow going down and a good runoff, and this can be left alone. So if you have that basic peripheral exposure, you can deal with these complications by yourself. The fourth thing I would say, if you're starting a TAVR program now, you're very lucky. You have all these systems and processes out there. You can adopt those for your own good. One very important thing is what you're going to do to monitor the patient's rhythm after TAVR. Figure out who gets a pacemaker, who gets to go home, who needs long monitoring. There's various guideline documents. This is the US ACC. I just think there's one in Europe. This is ours at Mayo Clinic, developed by my colleague, Mac Alid. He's looked at our own data in detail. We classify patients immediately post-op into group 1, group 2, group 3, and they have a different flow depending on the group that they're in. Now, avoiding complications is what we all want to do, and I will tell you that if you can systemize processes in your lab, this will avoid complications. We have a TAVR safety checklist that the technician reads out before every TAVR is deployed, and we have a sterile cockpit environment, meaning at this point the technician says, everybody be quiet. The consultants shut their mouth, everyone listens to the technician as they read through each of these and wait for an answer. Once we have all of the answers, we're allowed to go ahead and deploy, and this will save complications. Here's an example of a process, actually of a self-inflicted complication. This was our mistake, and we changed the process to deal with this. Look at what happened here. The valve embolized. Now think about how that might have happened. This was an error. So this is an old valve, when we deployed the valve, we pulled the pigtail back. That's how you normally do that and allow the valve to deploy. Now this was a femoral pigtail, a left femoral artery. The left femoral vein had the pacing wire. With all the lights off in the room, instead of pulling the pigtail, somebody pulled the pacing wire back. So we lost capture and this valve got ejected out. So very, very simple. You won't think of this. So how do we deal with this now? We put a blue towel all the way over the pacing wire, all the way to the pacing box, so you can't be tempted to pull the pacing wire. So these simple processes will trust me, they will save your patient, they will save your problems. Here's another protocol that we developed because of complications, an 83-year-old male who had tamponade immediately after TAVR. Now I will tell you, the person who's doing the echo, when they diagnose a tamponade, they're going to tell you, don't worry, I'm going to figure out the cause, and they'll be scanning the aorta, they will never figure out the cause of your tamponade on echo after TAVR. And it's only usually one of a few things, and I would strongly urge you do an immediate aortogram, an immediate high volume contrast LV angiogram. Here you see this was aortic annular rupture. This was a real fatal complication, but the diagnosis was made with an LV angiogram. Here's a different case. You see the drain is in, and this is the cause of tamponade. You see there's a perforation in the left ventricular wall here. This was when we used to use the Lundaquist stiff wire, a knuckled stiff wire perforated. But this was managed conservatively with prolonged drainage, and the patient didn't need to go to the operating room. This diagnosis was made only with a left ventricular angiogram. You will not make this diagnosis with echo. So TAVR complications are inevitable, preparations and protocols are invaluable. I've listed some of the things that we have ready, and I've mentioned pericardial effusion in particular because I think this is really helpful to have the angiogram done. So I'm going to close out now saying thank you for your time, everyone. This is my summary. The only two things I do want to stress here is this one. Humbly self-retrain in femoral and closure. Trust me, that will help you. And the final thing, to monitor your outcomes, share your data, and participate in research. And thank you for your time.